Actually, I think the first time we met was we were doing a symposium at NYU, and Marcos, all the speakers you're going to hear, I think Marcos has been at everyone's hometown. Am I right? Mark, so you can see why he's just a wonderful advocate. I think it was him that once told me he learned something every time I speak, but I learn something every time he speaks. Okay, our next talk before break is myself, and it's on diagnostic studies for RSD. So hopefully at this point there's not any question in anybody's mind anymore about the role of thermal imaging. When we first started doing this in the 80s, people said to me, but you can't measure temperature from 8 feet away or 12 feet away. I think we're past that. Everybody knows that we can do that. I'd like to tell the story that I thought that Desert Storm would have proved it. I thought that maybe all of these Gulf Wars would have proved it. But the physician community finally believed you could measure thermal imaging when they saw the movie Terminator. So that's what did it. Okay. All right, so let's talk about the diagnosis of RSD, CRPS RSD. And I use RSD because we spent so many years, so long, getting the word RSD known. In fact, if you haven't figured it out already, not all chronic regional pain syndromes are dystrophy. They're simply not. Oh, Marcos, I need the USB thing. It's on your laptop. Yeah. And so you're going, why is he pushing my laptop over? All right, let's see if it'll work now. All right. Okay, so if you look at the anesthesia texts, Cousins or any of the classic anesthesia books, they're going to tell you that there are only 3 ways to diagnose RSD. So we've gone over what is RSD not. We've gone over thermal imaging works. There's a lot of applications for it. Now we're going to go over how do we use thermal imaging or other diagnostic tests to prove RSD, and how do you read it? How do you start making some sense of this so that we can use this in our practice? What are the ways of describing this in a way that makes sense to us so that when you get a report, you understand what it means? So if you read Cousins, they're going to tell you that there's actually only 3 objective ways of proving RSD. The first is by doing tests of sympathetic function, and these are skin galvanic impedance studies. And you'll find as we go along, those actually follow acupuncture meridians, and these galvanic impedance studies, in fact, are what we call in physics fractals. They, in fact, are the same thing as thermal tomes or thermal images. The second group of tests are tests of skin blood flow. And it would be plethysmography, such as we use in segmental vascular studies, or thermography, and what we call more and more sympathetic skin response studies, because we do all of our tests under cold stress, so that we're in fact doing a sympathetic skin response. And believe it or not, the third accepted criteria is visual analog pain scales, or tests of pain. At least in my community, and I believe in most places around the world, let alone in the United States, most doctors still think that they can make the diagnosis of RSD by simply performing a sympathetic block. And we use the option of a stellate block because in a stellate block you can say that I saw a Horner's. But in fact, it's been published numerous times. This particular reference comes from Matsumoto in 1992, that the presence or absence of a Horner's does not mean that you obtained ipsilateral warming. And what Matsumoto did is that they found they injected 10 cc's of bupivacaine, and at only 6 out of 10 times were they able to prove that they got ipsilateral limb warming, even though they had a clear Horner's. If they did 4 cc's, or 5 cc's, then only 4 out of 10 times did they in fact obtain the skin warming of the limb that they were trying to get, even though they obtained a Horner's. And then they reported that 3 out of 10 of their patients said that their symptoms were worse, and that 1 out of 10 said there was no response at all. Well, what does that mean in our clinic? What it means is you sent a patient over to get a stellate ganglion block to see if they had dystrophy, and 3 out of 10 times they came back and said, I was worse. Now, usually when we see a report, oh, this patient has pain, I'm going to do a stellate block, and they come back and they say they're worse, the general thought is this person's nuts. You know, I know he got a stellate block. How could he be worse? Okay, but in fact, we never measured what was actually going on with that patient. For years, for decades at this point, I've been trying to promulgate a science where we created a modality called electric sympathetic block, where we use an electrical current based on ion cyclotron resonance that's directly targeted against the voltage gate of the sympathetic fiber. So we studied this in 1989. And what we found is that we were able to obtain the ipsilateral warming. Here's our cold limb, and there's our warm limb 20 minutes later. But we only were able to obtain it in 6 out of 10 of our cases. And in 3 out of 10, we're not able to get any change. And 1 out of 10 actually said they were worse. And lo and behold, when we imaged them, they actually were worse. They had a paradoxical response. Even though we had done a block, they actually got colder afterwards. Paradoxic responses occur. Well, there is no stellate ganglion in the low back, so we can't look for a Horner's. So what radiology published in 2006, well, what happens if we try to use fluoroscopic guidance? Because we're nowhere there. We can see it. We're going to say that we know we did sympathetic block based on anatomical localization. So they took 13 patients and did sympathetic block under CT fluoroscopic guidance. They used 5 cc's of bupivacaine, and they found that 17% of the procedures were falsely considered successful. They thought that they had a sympathetic block, but when they did concurrent sympathetic galvanic skin response studies, they were simply wrong, and so the localization didn't give them the information they needed. What if we use pain score tests? To me, that seems like the least reliable, even though the literature says that there's something that we can use. I'm not a big fan of meta-analysis, but in 2002, the Clinical Journal of Pain published an article where they did a meta-analysis of all patients that had sympathetic blocks using pain score studies. And they found that only 29% of the patients had full relief of pain, 41% had partial relief, 32% had minimal or no response. That's not just across the board. Pain score studies by themselves don't give you or I the clinical confidence to know that we're successful in our objective of creating sympathetic block. Further, I don't care how you do the block, and I don't care what your methodology is, there's almost no literature in almost any format that tells you what the duration of relief is that you should expect, or whether or not a paradoxical response was noted. 3-phase bone scans for years was considered to be the hallmark for dystrophy. And I think, at least in my community, and more I'm seeing people rely less and less and less on it. But certainly in the 80s, certainly in the 90s, and probably in the first 2000s, that's the first thing everybody did. More and more I'm seeing people are just saying, well, I don't care what the bone scan says because I know it's not that specific. Bone scans are very specific, I'm sorry, but they're not very sensitive. And the problem is that you have to have as much as 30% bone loss until you're going to have a positive bone scan. So by that time, everybody's made the diagnosis because the patient's got advanced disease anyways. So that leaves us with medical infrared thermology. Thermology has very high sensitivity, but unless you know what an RSD lookalike is, for example, like we've reviewed in our previous talk, unless you've done a lot of the pitfalls that Dr. Brioski's talked about, and you'll see more of them throughout the day, and knowing what the difference is, the specificity isn't that high. You have to know what is it that you're reading. Back to the point of acceptance. If you look at the Department of Defense, I don't think anybody would argue the Department of Defense uses thermal imaging for all kinds of military applications. It's used in industry, it's used in engineering, it's used in the physics literature. And in fact, if you look at the basic research science medical literature, thermal imaging is always used. It has full acceptance. Because it objectively documents not only the presence, but the key words that we're going to be talking about over and over in this talk is the distribution and the mapping of that distribution of skin temperature change. It assesses physiology without ever touching the subject. Well, here we have a patient that was referred that has RSD of the left lower extremity. We got a bone scan done, however, and it was normal. Well, how could that be? Bone scans assess only bone. They have low sensitivity. And many, many of us have seen patients that we thought had RSD, someone said the bone scan was normal, or even that had a sympathetic block. I'm so proud, I recently had a family practitioner refer me a patient, had a normal bone scan, had a normal, no response to stellate block. She had clearly positive dystrophy on thermal imaging, called up the PCP, and he said, I knew she had it anyway. Okay? And the problem is because these tests are just not sensitive enough. The thermal imaging exam, however, clearly showed the heat emission asymmetry pattern, especially in the dorsal aspect of the foot. Thermography measures and maps skin temperature change. It's not rocket science. The vasomotor maps and skin galvanic impedance studies overlap each other. If you look at the American Academy of Osteopathic Medicine, the collective works of Erwin Kuhr in the 40s, he did thermographic studies based on skin galvanic impedance studies and overlapped them. In every instance, they overlapped. This is 70 years ago. And I'm going to tell you today, and we hope by the end of the day you'll understand that the mapping, the distribution of that asymmetry pattern can give you insight as to what's generating the dystrophy. We can start treating the source, not just the symptom. And if that study is done under cold stress, then in fact you're doing a sympathetic skin response study. You're challenging the autonomic nervous system. Thermal imaging is not a picture of pain, and they do not necessarily equate to disc or spinal pathology. Now that doesn't mean that the disc doesn't create a C fiber response, and if you have an L5 disc and you get a physiologic reaction that tracks on thermal imaging at L5, they don't have a disc, it's nice to have structural and physiologic correlates. What it means is that the fibulocalcaneal ligament also tracks in an L5 distribution, and someone can have a sprained ligament in their ankle and show an L5 pattern in their leg. That doesn't mean that automatically that they have a disc. You, the physician, have to do your job. In 2006, the American Academy of Thermology published internationally peer-reviewed guidelines on thermal imaging. These were restated and updated in 2009. Thermal imaging is indicated for the evaluation of vasomotor instability, for mapping of vasomotor instability or generator identification, for the assessment of RSD, CRPS types 1 and 2, thoracic outlet syndrome, vasomotor headaches, and Barré-Liu. For the evaluation of vasospastic and inflammatory disorders, shoulder-hand syndromes, and other dysautonomias. The evaluation of trauma, unexpected post-operative or post-fracture pain, the evaluation of the clinical improvement, progression, or spread of disease. There's a pre- and post-procedure assessment to see if you want to evaluate whether or not your treatment was effective or is working or has changed the physiology. Determination of the extent of involvement of impairment ratings. If you look at the AMA guides for impairment rating, you're supposed to rate the limbs or the body parts involved. You could say this person had a foot fracture, this is their body part, you rate the foot. If you didn't do thermal imaging, you never would have known if it was the entire limb. You don't measure, you don't know. For confirmation of IASP inclusion criteria, if you look at the International Association for the Study of Pain, they will tell you you have to measure thermal asymmetry patterns in order to even make the diagnosis. So these are standardized, worldwide recognized criteria. And the only contraindications are technical complications that preclude adequate skin temperature study in the uncooperative patient. Skin temperature is largely regulated either through peripheral or hypothalamic components. It is rare that you will see a patient with dystrophy that you're asking yourself, does this person have a hypothalamic syndrome? Dr. Briosky stole my slide on skin temperature physiology, but in fact, I think I stole your slide, but, but in fact, skin temperature, AV, and anastomoses are controlled by the autonomic nervous system. All right, well, let's get on to what is it that we're looking at and what is it we expect. You don't take a hot glass of water and put it in the refrigerator and expect one half to be hot and one half to be cold. You expect it to equilibrate. And you expect the human body to do the same thing. So if you're in a cold stress environment, you expect there not to be a change from side to side. And in fact, as Dr. Ryoshiki mentioned, Uematsu first showed all the data. If you use a greater than 1 degree centigrade change from side to side, that is an abnormal finding. Dr. Ryoshki's gotten some very detailed specific numbers that are lower than that. We use 1 degree cut. We're way over his standard deviation numbers. Thermal imaging it's not that they're just pretty pictures. We always set up our temperature palette so that there's 10 colors, and there's always 1 degree centigrade change from color to color, so we know we're looking at a 1 degree centigrade change, warm to cold. And you shouldn't be seeing that change from one side to the other that's greater, that is in that color palette. They should be the same. If there's a change, then it's greater than 1 degree centigrade, it's abnormal. We very much ascribe to controlled conditions. In fact, if you come to my office, you'll see that our thermal imaging room has its own HVAC, that the vents come out of the ceiling, they don't blow on the patient, they go on the ceiling walls, and you can tell that that's true because the HVACs have their dust marks on them, and it goes off the ceilings and then down the walls, so there's no direct heating or cooling on the patient. There's no outside walls. You're not worried about infrared contamination from the outside. And we have a temperature-controlled environment. Now, we like to do our studies at 15-minute intervals. We like to repeat them so that we know what's going on with physiology over continued stress. So here we have an example of an asymmetry pattern where it's not showing up in all views, but we see that in the dorsal aspect of the arm and forearm. But as we go along, the patient eventually equilibrates. So this is a patient that has a sluggish sympathetic response. So heat emission asymmetry patterns are usually due to an abnormal sympathetic response. We want to keep in mind venous disorders, RSD lookalikes. We want to know what they are so that when we're reading that pattern, we don't confuse them with what might otherwise be considered dystrophy. Though for most patients, for most physicians, in most cases, for pain patients, 90% of the time, it's not going to be one of these zebras. It's when you hear hoofs, think of horses, it's going to be a dystrophy patient. And one of the key things that I'm going to try and teach throughout this is that different structures have characteristic asymmetry patterns. You can read the pattern and say to yourself, only these particular structures map this way. I know where the source of this is coming from, or at least now I've narrowed the universe of where this generator is. When we describe asymmetry patterns, you can use several different methodologies. You can just use an anatomical correlate. There's a heat emission asymmetry pattern or abnormal sympathetic skin response study over the maxillary portion of the face. You understand what I'm saying. You can describe a region. It can involve the entire limb. You can describe a dermatome, as in the myofascial pictures we described. You can describe a sclerotome. Some people call them thermatomes. Or you can identify the localized hotspots and localized, or which side is cold. So let's see what that might look like. Well, this is a patient where it doesn't matter. And so our views I've taken just for teaching purposes. I've limited the number of views, but there's like 54 images that we do in each one of these studies. But in this case, you see that it doesn't matter what view I'm looking at. In each case, the left lower extremity is cold compared to the right. When you see every view, all body parts, every section of that limb involved, it's RSD. So in this case, you might describe it of, there's a heat emission asymmetry pattern, abnormal sympathetic skin response pattern in every view. This is consistent with left lower extremity RSD, or sympathetic pain syndrome should be considered. We'll talk about how to put your impression in there. On the other hand, in this case, it's not in every single distribution. Rather, it seems to be most predominant in the lateral aspect of the thigh with radiation to the dorsal aspect of the foot and leg. That's an L5 dermatome. All of us know that. This is a sympathetic asymmetry pattern, sympathetic skin response pattern tracking an L5 distribution. This might be a sclerotome if somebody would have changes in an L4-5 distribution where we see a heat emission asymmetry pattern in the lateral aspect and anterior aspect of the thigh.